Good afternoon. I'm Dr. Christopher Martin, the Medical Director for Education for the Royal Victoria Regional Health Centre. And this is March 2022's Medical Grand Rounds. Unfortunately, still virtual. We are hopefully coming out of the pandemic. However, meeting in person is still not a thing. So we are doing this virtually, and it'll be recorded and posted on the education website for all to view. We're very lucky to have with us today a special guest from CritiCall Ontario. Martha Cousins is a client relations manager with CritiCall, an expert on CritiCall as an organization, and we welcomed her here to discuss CritiCall, its role in Ontario, what it does, and also to speak about the life or limb policy, which is a big part of CritiCall's mandate, is moving the patients under this policy. So I'd like to welcome Martha. Thank you so much for joining me on our Medical Grand Rounds today.
Thank you for having me.
Wonderful. So we'll get right into it. So what is CritiCall?
So CritiCall is a one number to call 24/7, 365 days of the year, emergency consultation and referral service for hospital-based physicians in Ontario, caring for patients who require urgent and emergent care. So what we do is we assist hospital physicians by facilitating consultations with medical specialists and/or help with referral decisions for urgent and emergent patients to the appropriate levels of care with Ontario and outside of the province if it's necessary. So there isn't any other service in Ontario like us, and we're unique within Canada.
Got it. And so urgent and emergent only. So if I have like a non-urgent question about, a medication or something, that's not really the role for CritiCall.
Not within our scope, no.
Got it. Okay. And so I think you just kind of discussed the mandate, but where did CritiCall come from? What's its background?
Well, yeah, so I don't know if people know this, but we're a provincial organization and we're based in Hamilton. So we started in 1988. We began as a local program in a hospital here in Hamilton, and the switchboard acted as our call center. And so in the 1990s, there was a coroner's review that highlighted some challenges that physicians were having from smaller hospitals trying to access emergent care for their patients. And in 1996, we were selected by the Ministry of Health to provide a province-wide support for physicians. In 2014, the launch of the Provincial Life or Limb policy took place. And then in 2015, we began coordinating transport for those life or limb adult patients that came through our service. And today, we have about 70 employees.
70 employees. Wow, that's grown quite a bit.
Yep.
And so now, who does CritiCall report to then? Like who's your governing?
Yeah, so we're funded by the Ministry of Health. So that's who we report to.
Okay. And who's the manager? Who's in charge of CritiCall? Is there a boss?
So I would say the Ministry of Health is our big boss. Isabel Hayward is our executive director.
Isabel Hayward. Okay,
I
recognize the name, and I've seen her. I think I've seen her speak. Great. And so, what are the obviously all the calls in Ontario that are urgent emergent go through CritiCall. Like, what kind of volumes are we talking about?
So most do. For the fiscal year of 2021, we had over 44,000 cases come through our call center. And then, so we link referring physicians with consultations, and then sometimes those consultations are acceptances. There was roughly about 17,000 transfers. So what that means is we're not always calling RVH for an acceptance. Sometimes we're just calling for a consultation. More often than not, a consultation does not result in a transfer.
Got it. So about a third of the patients you help facilitate that initial consultation end up being transferred.
Yeah, it's about that.
Wonderful. And but why, for physicians who don't use CritiCall, why wouldn't we just call the hospital directly? Like, why are we going through you guys?
Well, I mean, we're the one number to call to get what you need. So I facilitate something called the service inventory collection process. And that's basically gathering or confirming information across the province from every acute hospital. What services do they have on call for us, and are they still on call and still available? And our call agents need that information when we're looking for the referring physician, what they're asking for. We have a database and a program that allows us to search for that information. If we don't have correct information, we're going to call the wrong hospital. We're not going to be, and it's going to waste time. So that's one thing. We know what's going on in the province, probably more than most individual hospitals would. And if you need to call more than one place, so let's say a case starts off looking like a certain kind of case, and then now you need a different kind of specialist, our call agents will get that specialist on the line. You don't need to search for it yourself. And especially if the patient is life or limb, we're going to help with the coordination of transportation.
Yeah, I think the other advantages that I've seen is that, let's say if a small hospital needs ICU, but also they have a GI bleed and they need to have gastroenterology, that the CritiCall is able to facilitate getting both those consulting physicians on the line with the sending physician, so you can talk to everybody as opposed to
That's right. That's a great example.
that's a big one for us, because often we can't accept the ICU unless the general surgeon or the GI doctor or the vascular surgeon is able to help. And also about recording the calls and time stamping them. That's another advantage, isn't it?
I think so. So, I mean, we have the calls are recorded for training purposes for our call agents, but they are also helpful for us if we need to. So let's say there was a case that maybe took a little bit longer than expected, and a hospital calls us, you need to call us quite quickly after if you have a question about a case and we need to listen to the audio, because I think we keep them for 7 days. We don't provide them to the public, but that we would be able to listen to the recording if there was something specific that you needed that we weren't able to get from the interactions from our application. But every call we make, how long things take, they're all time stamped. So we can tell you, we called this hospital at this time and what the outcome was. When did we call the next hospital? How long did it take us to make the first call? All those kinds of things.
Yeah, I've seen that data be useful in a kind of a quality of care review, looking at patients being transferred and timelines. So I think the timeline is very valuable for trying to improve that quality of transferring patients across the province. And the who else works at CritiCall other than yourself and Isabel? Like, how many call takers do you have? What's their training? Tell me.
Sorry, I don't know how many call agents we have. I would say we probably. Yeah, we probably have over 30 or 40. In total, we have about 70 staff, and we have our bread and butter is the call center, obviously. But we also have a communication and client relations department, which is I'm part of, quality and strategy. So we're also always looking at how we can do things better. Business innovation and reporting. So we have, I don't know that we're going to ask any questions about it, but we do have a business intelligence tool that we launched last March, so a year ago. That allows hospitals to see their data quite quickly, like within 2 weeks after a case has been facilitated. How long did it take? How long did it take us to call? How long did it take for you to accept, and things like that. We have information and technology, and then also privacy and security. So back to your question about call agents and training, they do get months of training from our in-house educator. They are not clinical, so they're not nurses, but many of them have had, they've taken medical courses, transcription courses, things like that. And, many of them are, what do you call it? I was going to say not legacy, but, they're veterans. They've been doing this job for a very long time, and they know what they're doing.
Yeah, no, I've found that, I'm always surprised on how nice and kind and knowledgeable they are. I was actually surprised when you told me they didn't have any medical training, because it seemed like they knew kind of, you're looking for this service, when I said what the diagnosis was. And so I've always experienced a lot of professionalism from those call takers.
Sure.
How many are on? Do you roughly know how many are on at a time? Because if 40, I'm trying to do that, 44,000 calls a year.
Yeah.
I mean, that's multiple, hundreds a day, I think. My math's right. So
yeah, I wish I knew exactly, but I think it's like 4 or 5 per shift. But then we do have, we analyze our data and we look at our higher frequency times of when we're getting more calls, and we staff accordingly.
How was your staffing during the pandemic? Were you also affected by?
I think we were, a little bit affected because, cases of COVID and, yeah, and it's just affected everybody. So we've been affected a little bit, but I think by and large, we figure it out, just like all the hospitals are figuring it out too, even if they're short-staffed.
So the call takers we've talked about, so there are medical directors or physicians that work for CritiCall as well. What's their role?
Yeah, so I'm not sure that everybody knows that they exist, but we have our provincial medical director, who is Dr. Desmond Bone, and then we have associate medical directors, and really what their role is to provide direction for cases that might require escalation. So as an example, if a referring hospital is calling about a patient that they're declaring it as life or limb, and the consulting physician is saying, well, this really is not a life or limb case, and you can't resolve the issue yourselves, then you can ask the call agent to assist by calling one of the associate medical directors that we have on call at the time. So we have 10 of them in total. 6 of them are dedicated to adult care, 2 of them to pediatrics, and 2 of them to perinatal.
Mm-hmm. And then my understanding is that they help to facilitate the discussion and again trying to find the patient home, but they themselves, they can't decree that a patient be taken by a certain hospital, but more of a facilitation role. Is that correct?
Yes, mediation, adjudication.
Mm-hmm. Yeah, and I know several of them, and they're all very highly trained and very good physicians. So I think a resource that people don't know about when there is these conflicts, and they are available 24/7 to call. There's an on-call director, is my understanding too. So
Yes, yeah,
maybe a resource that when there are conflicts that everyone can use to help get the patient to the right location in timely fashion.
for sure. Because we wouldn't want a hospital to feel like it didn't go the way that they wanted it to go after the fact, when an associate medical director could have helped participate and possibly resolve it more quickly.
Yeah, absolutely. So it's a resource for both sides. Is we're going to talk about the life or limb policy now. So
Sure,
let's move on. The life or limb policy, you said, came out in 2014, and where did that come from?
So the life or limb policy, so the Ministry of Health developed it in response to recommendations from the Office of the Chief Coroner for a provincial no refusal policy when critical injuries or conditions were a threat to a life or limb is involved for a patient. So, and this, as I said a little bit earlier, was in response to a number of high-profile cases where emergent care was delayed because physicians were not responding to our request for consultation or transfer, resulting in some adverse outcomes for those patients. The life or limb policy states that physicians must consult for patients with emergent conditions where access to care needs to be available where appropriate within a 4-hour window. And a failure to provide this would result in risk to life or limb for the patient. So when a referring physician calls CritiCall, we always ask them if they're going to designate or declare that patient as life or limb. Then when we call the consulting hospital and the consultation takes place, we ask the consulting physician to tell us whether or not it's a confirmed life or limb. Sorry, stepping back just a bit. When we are, we're treating it as a life or limb case, we're going to contact the nearest hospital with the specialties and resources that are available and ask for the specialty that's required. And then we let the switchboard know that it's a life or limb call. So it's important that we know that at the beginning of the conversation.
Yeah, and I think that with life or limb, there's a lot of confusion about the criteria, and the definition truly is 4 hours, and with threatened to life or limb, and I think it's a very somewhat poorly understood concept by both sending and receivings, and as is evident, I think, by some of the data that showed that 50%, not even, of declared life or limbs are actually accepted life or limb. What do you think contributes to that?
Well, I think that, life or limb, you and I talked before about, is there a strict definition of what's considered a life or limb? And there was discussion originally when the life or limb policy was developed and becoming operationalized with CritiCall. Should there be diagnoses that are considered life or limb? But it's not that simple. And it can depend a lot on contextual factors, like what does the referring hospital have? Because something that for them, they may see it as life or limb, but the consulting hospital does not, because they do have some of those resources. But there's lots of things that are involved that would make it difficult to say, absolutely certain cases are life or limb, but things like human resources, geography, and time, those are all things that have to be considered.
Yeah, I think the human resources and capacity have been a big stress, both from the sending and receiving. So, we as a more tertiary ICU, we do get requests from smaller centers that have patients on vasopressors and they emerge, and they don't have an ICU in their hospital. And from their perspective, that one patient on vasopressors is overwhelming their nursing staff and their physician resources. From the receiving, they look at the policy and say, well, 4 hours, they can be on pressors for days in the emerge if you have enough levofed to, I don't see how this is life or limb. And so it's that I think there's the value of that facilitation between the medical director, because I think some of the bigger centers don't realize how much that patient can affect that small emerge's ability to function. And also there's just uncomfortableness with that level of sickness, even though that might be the healthiest person in the receiving ICU, it is the sickest patient in this small town emergency department.
Yeah, you've got it.
Yeah, on the other side, if a ICUs, we've been running at capacity for years, and even before COVID-19, we're always full and, very strained nursing resources. And to take over census puts a lot of strain on the tertiary ICUs as well, and their nursing staff and burnout. And so, if we see a patient who's on a low dose level of vasopressors, we're very hesitant to say, well, we'll make our nurses triple patients to take it because we make room for something that we're like, well, can't they just go somewhere else that has more beds? So I think that there's, on both sides, I understand the struggles, and the lack of, if there's not a definition, there is a lot of gray area.
Yeah.
And I think that's when that discussion just has to happen with the medical directors.
Absolutely.
What about, in terms of life for limb, what about the LHINs? So, we used to have LHINs, the local health integration network, and then now there's some super LHINs or bigger LHINs. So, how does that affect life for limb?
It doesn't. So which LHIN the hospital is calling in and which LHIN we call for a consultation is about proximity for life or limb. So LHIN boundaries and region boundaries are not important.
And usual referral patterns, all that kind of stuff gets kind of thrown out the window with life limb. What if a patient has a life or limb issue, let's say a recurrent brain bleed, but it's followed by a specific neurosurgeon in a hospital? Can the physician request to speak to that center and still make a call life or limb?
Yeah, I believe so. We will do whatever we can to help. So if a referring physician is saying that patient has a history at a specific hospital, then I think we're going to do our best to get them on the line to help.
Mm-hmm. Okay. And what about repatriation? If I send someone out by life or limb and I accept them, does the hospital have to take them back in within 48 hours? And how does that work?
Yeah, so the idea, or how repatriation works, is we do have something called the Repatriation Tool that's a part of one of our applications, Provincial Hospital Resource System. And the idea is that if you do take a patient, accept them for a higher level of care, then as soon as they don't need that bed any longer, but they still need hospitalization, they should be repatriated to the closest, most appropriate or home hospital. So it may not necessarily be the hospital that sent the patient to you. It might be a hospital that is, closer to home, or one that they still need a specific specialty that isn't at their home hospital. So yeah, basically, if you're asking for that patient to be repatriated, the accepting hospital should be taking that patient back within 48 hours of the requested patient repatriation date.
Mm-hmm. Yeah. And now, what are there any consequences to the hospital for not being able to take them back? Because that's a very common thing where, the hospitals, they send the patient out because they need to go out, but then when they go back, we can't take them because we're full. How does it get escalated? How do we keep the patients moving?
Well, it doesn't get escalated by us. Unfortunately, we can't make hospitals repatriate. Usually my suggestion, if a hospital calls me and says, like, we're having difficulty repatriating this patient, I really just suggest that the two hospitals talk to each other and try to figure out what's going on, because that bed isn't needed anymore, but there's a patient that's still filling it, so they need to leave. So it's really, I think, about relationships between hospitals when it comes to repat and how you can improve it. There has been some repatriation through like the IMS table, and if something like that happens, of course, then that is, there are consequences, but
Mm-hmm.
not from CritiCall specifically.
Yeah, I agree. I think that, collaboration is always better. There's nobody at CritiCall has got a special repatriation stick that they can hit you with to make the patient back. And as you said, you guys facilitate and mediate and put the right people together as your role. Now, what is there a level of surge, though, going back to capacity? Is there a level of surge where a hospital is in that they can refuse a life for limb in terms of?
Well, if your hospital declares a moderate surge, then you can refuse a life or limb.
Okay, and I think a moderate surge is 15 or 30% over capacity. I can't remember which one.
It's over 115, I believe.
Yeah, 115. Okay, which unfortunately a lot of places were running. During the pandemic, we were at that for months. So, but even and I think the hard part is too is that now do you have an idea of capacity from when you make your calls to sendings, let's say for a non-life or limb policy, do you have an idea of who's got room in their ICUs?
We do. So we have the Provincial Hospital Resource System that has, actually right now we have one of our resource boards is the Total Hospital Occupancy Board, and it has like also acute beds and critical care beds for every hospital, what their total number of funded beds are, and then what the occupancy is. We also have other resource boards like that show for med surge, whether or not beds are occupied. And we have CCIS, Critical Care Information Services, which is any of your ICUs would use that application where you're entering information about your critical care patients. But I believe our call agents can look in PHRS and look at critical care bed capacity for hospitals when they're looking. And they need to know if a hospital they're calling has a bed. So for example, if a hospital has provided a consultation but really cannot take the patient, then the call agent can look and see if the hospital that they're going to call has occupancy.
Yeah, and I think those are valuable tools. I think we still haven't got to a point yet provincially with those good data systems, though, that the beds account for nursing availability, because you have a sick call, you may have beds, but no nurses available, or your acuity in your unit's very high, and nurses are single versus doubled. And I think that's always a challenge, because there's no way for CritiCall to know that calling in, even though it looks on CSIS like a place has 3 beds available, but we have 12 of 15 are vents, and we had 2 sick calls on this shift, so they're no longer available.
Yeah.
So I think and that's also the advantage of CritiCall, instead of just calling centers, that once if a critical agent calls me early in the shift and I said, sorry, we're full, we have no nurses tonight, even though it looks like we have 2 beds, at least that they won't then call again and waste their time and the sending's time looking for a bed. So, hopefully at some point we can get to a real-time data that shows kind of available beds, like not only empty beds, but available like staffed beds, which would be the holy grail, right, I think, of finding patients spots in the province.
I mean, I think our Total Hospital Occupancy Board this is our first kick at the can. I don't know if you know much about that project, but basically every acute care hospital in the province, we've tried to onboard their ADT system so that the information about their bed occupancy is being directly fed to our Total Hospital Occupancy Board. But it doesn't at this time. It says when there's beds unavailable, but that's a manual data entry field. We don't have a way right now to say when you're short-staffed and those sort of things that influence your denominator. But I hope at one point we will be able to build that, because what we've done so far, no one else has done, like to be able to have that information about how many funded beds at each hospital. We just have to work on improving its accuracy, which is just going to take some time, and that's just the way it is.
Yeah, no, I mean, the system's getting better and the data is getting better every year, and I think we are ahead of most other provinces for sure. But it's eventually it'll get real time. That'll be that's the goal. Now I'm going to switch back to life or limb for a second, and so I'm the doctor in the ICU, and they call me with a life or limb case, and I am grumpy and I say, no, it's not life or limb, and I hang up and I go back to bed.
Okay.
Turns out this case was a life or limb. Is there like a life or limb jail I have to go to, or how does that get fed back to me and my organization that, what, you should have taken that case?
Right. There is. It's not a big stick, but there is something that we do. It's been on pause during the pandemic, but in collaboration with CCSO, we basically look at any, when a hospital doesn't respond and we're calling and it's a life or limb case. So this is a declared life or limb case, or they refuse to consult or refuse to accept. So we take a look at those cases, and then we look a little deeper, and then our provincial medical director, he looks even more closely and tries to see which ones are, really you should have taken the call. And then what happens is we write a letter that basically has the time and the physician, and we send it to the hospital chief of staff just to let them know. And then CCSO should be getting a response from that hospital or chief of staff within 10 business days to basically have an explanation for why that took place. But we don't want to, we're not trying to, penalize people. I think a big piece of it is education for some hospitals. So that's what we'd rather do is, educate and identify when there was an opportunity that the patient, the consult should have taken place.
So that's perfect. Tangent to my next question is what educational resources are available? Whose responsibility is it to educate physicians, hospitals on both sides about life for limb, and that where's that? Whose responsibility does that fall under?
Well, we definitely, like CCSO has, or sorry, the Ministry of Health, I think the CCSO website as well, they both have information about what the life or limb policy is, and then we operationalize it. So the education that we have is how we operationalize it and what, how does it affect you? Like, we're going to call your hospital, we're going to tell the switchboard that we need this specialty and it's a life or limb case, and then your hospital will have an internal paging system that will let that physician know that they need to be calling back within a certain amount of time because it is a life or limb case. So we have on our resource page on our website, CritiCall.org, www.criticall.org, and there's like quite a few different resources that talk about our call center and what our service does, and it includes information about life or limb.
Okay, well, it's a good resource. So criticall.org is one, and the CCSO has a policy. And I really think, I think that we were talking about earlier about the data on the number of CritiCall declared life or limb versus receipt versus actual. I think that data, including the breakdown of those cases, would be very valuable for physicians to see. So yeah, I'm encouraging. I think that education piece is important for both sendings and receivings. Now, I understand you just sent out a survey about life for limb to physicians who use it. Tell me more about that.
So the survey actually wasn't about life or limb. It's focused on, we've received a little bit of funding to develop a proof of concept that could help improve and like modernize how we facilitate our calls. Not necessarily facilitate, I should say, but how we can bring our physicians together and how they're able to communicate with each other. Mm-hmm. So we have an idea of what this application or, prototype could look like, but we wanted to get feedback. We did talk to some physicians. I interviewed a few physicians before, but now we've sent out a survey to, over 30 hospitals, asking them, questions about what are some key functions and features that you would like to see when you call CritiCall. How important are they? And then a little bit more information about what do you need when you're going to accept a patient? What kind of information do you need? Like minimal, things like that. So yeah, we've sent it out. We've actually gotten a really good response from Royal Vic, but if anybody still has it in their inbox, please go ahead and complete it.
Thank you. I will do it right after this.
Thank you.
So it's for both non-life or limb, just communication in general, which, and are you looking at like an app-based kind of solution?
I think so, yeah. Yeah.
That's very cool, though. I think that
it is.
Be helpful, especially, sometimes waiting on the phone is the longest part, even though as fast as CritiCall moves, that if we have something we can take with us and we get some kind of secure PHIPAA compliant text or message might help facilitate things. I know that our paging systems move in that direction as well. So that's exciting. I'm anxious to see about the results of that survey. Okay, I think I don't have any more questions for you. Do you have any points from CritiCall perspective or stuff you'd like us to know about your organization, your roles, or future directions?
Sure. I mean, number one, we're on Twitter. So if anyone's on Twitter and they want to start following us, we're new to the game. We started, I think, 2 months ago. So please do follow us. We're also just launched on LinkedIn. But we built this business intelligence tool that we released last March. And I really, we used to send out, part of the client relations role would be to send out these static reports to hospitals every month. We never really knew how much people were reading them and how useful they were. And many of them were 30 or 40 pages long, which anybody's going to find daunting, right? If whatever information about your hospital, you want your specialty and you want it to be succinct. So the business intelligence tool allows you to go in, look at a specific time period for your hospital or any hospital in the province, and then look at all your cases or just life or limb, pediatric, adult, neonatal, and then you can see, how many did you consult for, how many did you have to send out and why, how long did it take for that patient, for you to accept that patient, a whole bunch of different dashboard metrics. So I encourage people, if they're not already, they don't already have a Core BI account, to get one.
Yeah, I definitely, I hope we do have one. If not, I want one, because that would definitely help us with our own numbers, but also our regional numbers, because we want to be a good partner to our small organizations in our region. So knowing that data would help us know if how many are we turning down? How much more capacity do we need to build and we expand? So that's very valuable.
Yeah.
Excellent. Anything else from CritiCall's
I think
world?
that's it. I mean, we love working with Royal Victoria and no complaints.
Oh,
So,
thank you.
thank you.
I really, and I mean, I appreciate so much what CritiCall does and how it does facilitate movement of patients and organization. I know, you're closely work with Orange, another organization I work for. Again, I think it's a great team effort, and no more has it been evident during the pandemic. And I want to thank you and your team for the Herculean efforts you must have had to move all those ICU patients during the surges over the last 2 years. So thank you from our behalf to you and your team.
Great, thank you.
Thanks again for joining Medical Grand Rounds. And if anyone has any questions, would you be okay if I forwarded some contact information for any physicians or staff that have extra questions?
Absolutely.
Wonderful. Martha Cousins, our client relations manager from CritiCall, thank you so much for your time.
Thank you.
Bye.